Welcome everybody to the last of our webinars for the Canadian Health Workforce Network 2021-22 season. My name is Ivy Bergeau and I'm very pleased to co-lead with many others, the Canadian Health Workforce Network. I'm very pleased to have our speakers with us today, Andrea Baumann and Mary Crea-Arsenio, and I will pass over to them. And they will walk us through the latest from their research on long-term care health workforce issues. Welcome.
Thank you, Ivy, and welcome everyone. I'm Andrea Baumann, and I'm going to say a few introductory remarks, and then I will be passing it over to Mary, and then she'll pass it back to me. And I see some of our co-investigators are online, and we'll talk a little bit about the complete work at the end of the webinar. We're not focusing on staffing per se, we're rather focusing on aspects of long-term care, of which of course staffing is an issue. And in some ways it may lead up to staffing as one of the major issues, but it's certainly not the only issues. So you'll see from our presentation the various issues we're going to discuss. So, Mary, next slide, please.
What's wrong with the sound? Well, it's often like this.
Just going to remove that little. So this is only one small part of a large study we did for CIHR, which included investigators from McMaster, Montreal, Maastricht, the University of Toronto. And the full report will be in June. Actually, we hope the late June issue of the Journal of Healthcare Policy, and it was funded by CIHR. And at the end of the webinar, we will show you the titles of the articles, which again, we'd be more than willing to send out to you once it's published. Next slide, please. So I'm going to pass it to Mary in a second. I just want to give a shout out to many colleagues who have worked very diligently over the past many years in this sector. Pat Armstrong, Carol Easterbrook, Dr. Samir Sinha, our colleagues in Nova Scotia, Saskatchewan, Andrea Picard, a columnist who also wrote a book, again, highlighting the many long-standing issues in long-term care. And we're hoping that this work will add to that. We have another couple of issues we're going to bring up today, and it'll be interesting to get any comments or questions. So Mary, I'm going to pass it over to you for now.
Great, thanks, Andrea. So hi, everyone. Thanks again, Ivy, for hosting the webinar. And as she mentioned, I'm Mary Crea-Arsenio, and I work with Andrea and the larger team at McMaster University. So I'm going to present a little bit about what we've done as part of the research. We're going to focus it on a couple of the major studies that Andrea and I led, and at the end, as she mentioned, we'll talk about the larger group and all the studies part of this large collaborative research. So as you all know, long-term care is a sector that has had decades of issues. And it seems that over time, the same themes have emerged related to staffing, related to resident care, accountability, physical structure. These themes emerged out of many reports. There have been over 50 identified only in the past 2 years, where people have tried to ring a bell related to some of the challenges that long-term care as a sector has been facing, and that, really that there would be some dire consequences if change didn't occur. Then COVID hit, and as we all know, back in March 2020, we didn't expect for it to be such a large and long ongoing pandemic, but it did. And really what we found during that time is that long-term care, as possibly predicted, had the greatest impact. COVID had the greatest impact in long-term care and in that sector. So when we decided as a research team that this was an important issue to study, it came out of many media reports of the stark, the tragic, the dire consequences. What the pandemic did was really bring into public consciousness an awareness of what's been happening in the long-term care sector for quite some time. And so that gave an opportunity, a platform where we could start to have larger discussions where the attention really was focused and the public was part of those discussions. We had family members that came out and spoke, about some of the challenges, and the media really did sort of highlight for everyone how it was an important issue that needed to be considered. This quote demonstrates the commission, the COVID-19 commission report, where they also identified the many challenges over time and how the result of that has been quite deadly for long-term care residents and very tragic for their families. So what we want to focus on today are some of the ongoing concerns. There have been a lot of things that have come out of the pandemic in terms of changes, and Andrea will talk about some of those, the government response, but also some of the other solutions that have been identified through the research. What I would like to talk about is these ongoing concerns related to 3 areas: neglect, abuse, and social isolation. And these are 3 key areas that emerged from some of our research. So starting with abuse and neglect, really abuse and neglect in long-term care is defined under the Long-Term Care Homes Act. There's legislation in Ontario. I guess I should say also that this research that we're presenting now is focused on Ontario, but the larger study did involve Quebec and the Netherlands. So it was more cross-jurisdictional. So with abuse and neglect, we wanted to focus on understanding or identifying how abuse and neglect is measured, tracked, and identified in the long-term care sector in Ontario. So as I said, it's defined under the Long-Term Care Homes Act of 2007, which has now been amended and is now called the Fixing Long-Term Care Homes Act. But the definition has stayed the same. So we took that legislation and we identified our data source through inspection reports. I'll just do next slide here. So what we did was we looked at the Ontario Ministry website. There's a public reporting website of inspection reports, and every single report that's ever been published is on that website. So as a consumer, as a resident, as a family member, you can go onto that website and you can look up a home and you can identify the reports, and you can read through those reports. So if there's ever been a critical incident or complaint that triggered an inspection report, it is posted on that website. Now, the issue with the website is it's really hard to navigate, and from a data perspective, it's not easy to extract the information. So we decided to undertake this endeavor by pulling all inspection reports over a 2-year period, 2019 and 2020, from all homes in the province. So there's 626 homes. What we found during that time was overall, there were about 5,101 inspection reports that we pulled. 2,900 were in 2019, and then about 2,100 in 2020. That drop, so we did one pre-COVID and one COVID year. That drop in reports was really related to, there was a period where the inspections stopped. And so it looks like maybe there had been less done in that year, but it's really because there was that sort of interim period where they had to, they put the inspections on hold. So what we did from these inspection reports is we narrowed in on the group that were related specifically to abuse and neglect. And we again used the legislation to define abuse and neglect. And in each report, the inspectors do give a citation for the legislation. So we were able to identify confidently in the database which reports were abuse and neglect. And what we found was there were 628 reports over the 2-year period, 70% of which were abuse and 30% were neglect. what we thought was, as we gone through the reports, we did a thematic analysis of what the cases looked like. And we found that there were 4 major themes that emerged from that. So things related to failure to provide treatment, failure to provide care. We sorted, collated, and identified those areas of neglect. What we also did was we looked at how many homes had repeated offenses under the abuse and neglect category, because we thought, every home had at least one inspection. Over half of those homes had at least one incident related to abuse and neglect. But, there were nuances within those reports that, we weren't entirely sure just how severe each of those cases were. So we looked at those that repeated, and you can see on your screen here, those repeat offenses. It looks like the most severe homes had, over 4 reports related to abuse and neglect over that 2-year period. And what we found is, from our perspective, that, any report of abuse and neglect is one too many. And so it's part of our publication. You will see that was something that we thought. There are issues related to the way the reports were documented. There's some lack of consistency in the standardization of reporting. And we do talk about that. But we think that what this early study provides is some trends related to what's happening in long-term care in relation to abuse and neglect, and that those trends are disturbing to some extent. And the other thing we did is we looked at, well, what is the impact of neglect specifically on long-term care residents? And for this, we used a different data set. We used the RIE MDS linked to some public health data to examine the association between indicators of neglect and 90-day mortality of residents in long-term care. And again, we looked pre-COVID and post-COVID, or 1 year into COVID, excuse me, so 2019 and 2020 data. And what we found was, even pre-COVID, there was an increased chance of mortality for residents who exhibited signs of neglect. But during COVID, that increased to over 80%. And so again, this trend, putting together all these pieces, the trend is really not going in the direction we want it to be going when we think about the at-risk population that lives in the long-term care sector. So I'm going to pass it back over to Andrea, and she'll talk about the third key area that we focus on, which was social isolation.
So again, the issue of social isolation certainly became prevalent because of some of the procedures in terms of COVID. And we began to really wonder about, well, we saw the variation across the province. And wonder, why did it happen and what was the impact? Next slide, please. So what happened, which we thought was a big contributing factor to social isolation, was the restriction of the visitor policy restrictions. And I have to say, we're delving into it even deeper, seeing the regional differences in policies around outbreak protocols. But this shows you when an outbreak was declared and overall restrictions based on the definition. And again, there's quite a database on how this was enforced, the directives, et cetera, and so forth. And that will be, we're still working on that work. But again, the restriction on visitors, the restriction on essential caregivers, it led to some pretty interesting situations where people, and well documented by newspapers and many relatives in the newspapers, where essentially when there was an outbreak, they certainly weren't allowed in. And often we have cases of people in their room for almost 2 to 3 months. There was some variation in what homes did. Some of them allowed them out of their room to the dining room once every 2 weeks. This kind of thing. But we were familiar with very, very early work by Bowlby and some of the other isolation work. When you leave a person alone, no matter what age or stage, they're just not going to do well. This trend was very concerning. Next slide, please. So again, the loss of social connection to family caregivers, and we all saw those heart-wrenching pictures over the period of the pandemic in our two major national newspapers, more in one than the other, of families looking out the window or really communicating in that way. And there was also the loss of the substitute decision makers. So it wasn't just family members, it was also other decision makers. Then we began to wonder, what would be the legal issue? I mean, can we legally bar? We can, from a clinical perspective, clinicians will give their perspective on the control of infection. And that'll vary depending on the training. But what was the legal implication? So next slide, please. So again, we looked at the social isolation. We found legally that actually, from a human rights point of view, we really could not bar people, and that will be in the article where we had legal advice and a law firm working with us to basically say you can't bar people from healthcare institutions. Again, there'll be clinical pushback on that, and hopefully we'll have a vigorous debate about that in the future, about what would be standard protocol in an outbreak, whether we can truly bar relatives, decision makers, caregivers from a caregiving institution. So our province has looked at, obviously because of the paper and the pandemic, they had to look at solutions. And we've seen it that increased beds, of course, is a solution. And if you look at the bottom, you'll see where our increased beds in our particular province are going, with many more beds now given to for-profit. We have increased staffing, in particular in the PSW training, huge incentives for educational institutions and actually private institutions to increase their number of personal support workers in the province. Some of them with sign backs that they'll have to work in long-term care. Our concern is, again, increased staffing without changing of environment will not necessarily incentivize people to want to work in these settings. And we have, again, the increased inspections and inspectors. And even recently, there'll be more inspectors added. Again, our concern in looking at the inspection reports, I think this whole area of inspection has to be looked at. Planning care by inspection. We could have a vigorous debate whether that's the most effective way to move to a quality of care for the long-term care sector. They've also, the province has amended the legislation in the Fixing Long-Term Care Act and the Resident Bill of Rights. We don't have time today to go through those amendments. They are, of course, improvements. Again, will they necessarily lead to improvement in the actual care? Only time will tell, and actually close monitoring will tell. The other thing that, again, going back on the staffing, looking at the pie chart on the lower right side, is right now we have a mixed delivery model where we have many more unregulated workers versus regulated workers in the long-term care sector. What would be the appropriate ratio? Again, I think in the ensuing months, this will be discussed. I mean, again, it's not just about staffing. It's not just about people. It's again, looking at the total whole work environment. And that still has concern with some of the sites. Next slide, please. So again, we said, what are some of the solutions? Is there any good news in this scenario? And we decided to look at exemplars. Now, of course, we began this right at the pandemic, so we actually couldn't. Part of our design was to get into and look at actual homes, because previous work, some very good work, had talked a lot about physical plant, and I think Pat had gone again to Scandinavia in the early, a while back, and was very clear about, the environment and what some of these homes looked like in Europe, and how basically that wasn't the direction we were going. So we really wanted to say, are there homes out there? And when we started it, we had to develop criteria very quickly, because we conducted interviews rather than on-site visits. And so we looked at this in the first wave, and we looked at homes that had no active COVID cases in the first wave. And again, we looked at the communities with high rates of COVID, which is known as the red zone, because we thought if a home is able to stay infection free in a high red zone, what are they doing to prevent that? And of course, because of our connection with this, looking at inspection reports of abuse and neglect, they had no reported reports. So that's what we used in terms of our criteria. And we're just going to give a few findings today, which just gives only an inkling of how the system has to move, what type of reforms are necessary. So we're just sharing these early findings today. So next slide, please. So we looked in all these homes that we chose. We of course, we interviewed a variety of people. We interviewed, of course, executive directors, often directors of nursing, sometimes together, sometimes separately. We interviewed the cleaning staff, we interviewed dietary staff, and today we're reporting more on the leadership component, what the leaders of these homes talked about. And then we tried to look at what characteristics they had. And now we're actually following up with the physical visits to these homes, holding the first few visits only in the past 2 to 3 weeks, because it was the first time we could get in. And we're pleased to say that what we've seen and we talking to the leadership remains the same, which is interesting. And, some of our observations again have been confirmed. So we're actually pleased about that our early choice perhaps has some validity and can provide us some guidance on what exemplar homes should look like. So one of the characteristics of all the leaders we talked to is they moved very quickly in the pandemic. In fact, many we talked to started to see early discussions in January and began to prepare for possibilities, because long-term care homes have always had to deal with flu outbreaks. So they had the history of flu outbreaks and what they did and how to prevent cross-contamination. So several of these leaders really had their antenna out for early detection and saying, we're going to have to do something. And we did find, for example, that some of them stocked up on the PPE. They began to alert their staff and caregivers of, what might happen should this virus reach Canadian shores. The other thing is, there was nothing but praise for their team, and that goes every member of the team. Constant communication. They started effective strategies for mental health program with their staff right away. They didn't wait until now. Many homes are and many hospitals as well are looking at post-pandemic interventions, because healthcare staff in general have been stressed. And but what was interesting about these homes is they began to talk about it before March. They had we didn't do a study on staffing, but what we did observe again was a balance between regulated and unregulated staff, and a fairly reasonable ratio of staff to patient, and of course, or clients of home long-term care. There is no ratio, standard ratio, and that's been even a big discussion in hospitals. But we did see in some of the more egregious homes, lack of staffing. In the end, by wave 3, no staff. So some pretty scary scenarios played out as the pandemic went on. But these homes stayed consistent. They converted their staff to full-time right away. They reported to have a fairly good retention. They did not lose staff. So that consistency again showed, I think, strong leadership. Clear and consistent communication. They showed us, again, via internet or sent us information about how they communicated to their staff and their families. And again, had a communication plan, as again, all this was rolled out almost within a week of the pandemic, if not before. The other thing that was really important was they have strategic partnerships and resources. They didn't get, some homes again did this near the end of the pandemic, or they did it because they were really forced to create a strategic partnership. Like we were forced to bring in staff from the LHINs because they had no staff. That's not what we mean by strategic partnership. This is a partnership that was based on history. They either leaned on a hospital. One home, actually in March, asked their municipality if they could bring the Red Cross in, and the Red Cross came in and did an assessment. I think it was the second week of March, and the executive director talked about how helpful that was, and they trained the staff. And again, this decreased the anxiety, probably, I suspect, helped with retention, and certainly helped with, again, the continuity of care. Again, most of these homes had close connections to the community. So they had a lot of community support. You know, when they couldn't let significant caregivers in, they even continued physical changes to their home. They had donations. They continued to improve their physical plant, even in the context of a pandemic, which, you know, again, many homes we know were in crisis mode, and they were so far from thinking about additional physical infrastructure. They were really worried about no staff. And there were many homes near the end of the last wave where literally they were operating with no staff because all staff was out with COVID. So they didn't have this situation in these exemplar homes. And then the physical plant issues, as I said, they maintained continuity. Next slide, please. So, you know, again, this has been documented. Many authors are online today. You know, the focus on resident care, we put it in because we know, but in our movement around the different homes and being able just to get into the lobby, not the whole home, every single home in Ontario has this prioritized resident focused care. And in some homes, it simply doesn't happen. So again, having these philosophical on plaques, you know, it doesn't mean anything unless it's followed up with a lot of other aspects such as staffing. The other issue is redefining the meaning of home. There is a lot of concern, again, about building 300-bed institutions. Are we going to lose that concept of home? And these are all subjects of further dialogue. Again, this building on existing partnerships, the homes that did well, they have really important partnerships, whether it's with a hospital, whether it's with community agencies, whether it's their whole volunteer network. The exemplar homes had a large number of volunteers, which again was affected by the pandemic, but of course is back to playing a very significant role in the care of their clients, and it's important. And we put this in again, greater staff and family participation in meeting residents' needs. Can't emphasize enough. When the homes were closed down during the pandemic, it was estimated they lost 35% of their caregiving ability, and that's a lot. And when you lose 35% of your caregiving ability and you're unable to supplement that with your existing staff, you have a problem before you begin. The research team, we've been in support of the national standards, and at the rollout of the national standards, a lot of hard work, many very learned people provided input. And we are actually would say we push for mandatory accreditation. I mean, this can be, I suppose, discussed, but something has to change to make sure that the national standards are adhered to and used in a vigorous way. We, of course, based on our inspection analysis, we're sort of preliminary saying that we should move away from inspection as the only form of accountability. Right now, it is in our province anyway, the inspectors going in, the reporting, it is the one form of accountability that's available. And it's been around for a long time, inspections, long-term care. And maybe that has to be looked at, again. Next slide, please. So not surprising that our early findings, we would call for greater transparency, accountability. I don't like the word enforcement, and it would be great to have a dialogue about that. I don't think you can run healthcare enforcing rules and regulations. It has to be, there has to be situations where there is accountability, but if it has to be enforcement, it has to be to protect people. But so again, we looked at possibly a new accountability framework within 1 year reporting and a clear consequence structure. We had that difficulty in looking at the inspection reports, where the inspectors would come in a second time, often to check adherence, but it didn't always happen. So you would read the report and then you'd look for a second report, and it just wasn't there. So it sometimes wasn't exactly clear what had been done, what had been adhered to, what significant change had been made. And I mean, sometimes you could see it, but not always. So that closing the circle on accountability. And again, this issue of shorter timelines with explicit quality improvement expectations in the inspection reports may or may not help. I mean, ruling by inspection is only one way to do it. I would hope that maybe someday the sector would be so healthy we could move away from this type of strategy, but I don't think in the early days we can. And then these national standards, which are an important piece of work, can't emphasize it enough, integrated throughout legislation at the provincial levels. And then a detailed plan of monitoring, evaluation, and enforcement. So next slide, please. So not surprising that our work really only, I think, reinforces, again, continues to highlight the importance of changes in the long-term care sector. The chronic staffing shortages. I know many provinces have looked at pay, benefits, training, education gaps. That will all help, but again, it has to be seen at the home level, and there has to be a standardization across, I'm looking mainly in Ontario, across the province. In other words, it's not one size. One size should fit all. It shouldn't be for some homes and not other homes. It has to be more consistent so that families looking for, or friends looking for care for their loved ones can go anywhere in the province and have equity of care and be assured of a standard of care. We think strengthening provincial recruitment strategies are important to meet the future demand. And then really focusing, we always say, we didn't focus on staff, we did interview staff, we didn't focus on burnout. But again, looking at retention, quality of care through expanded access to mental health, including respite and paid time off. So some of that is happening across the province within the homes. Again, it depends on the leadership, it depends on the ownership, it depends on how well these are reinforced within, whether it's a municipal, not-for-profit or profit. Next slide, please. And I know many of the NGOs in this sector, the advocates, the writers, the researchers, call over and over again for recognizing family caregivers as essential. And we actually would recommend stopping nationwide visitor bans in future. This can be done. It's adequate access to PPE and training for essential family caregivers in reverse isolation procedures. We've done this in hospitals for years. I remember the days when we only had restricted visitors, right? And when we allowed hospitals to be open for non-restriction, I do remember saying, oh my, people saying this is going to be terrible. There's going to be increased rates of infection. But if family caregivers or, caregivers, however defined, are educated adequately, they can come into areas that have active infection if they're trained appropriately. And it can be done. You don't need to exclude them. It is perhaps seen as more work by those in the working environment. But again, if it's a philosophy, there was a home in England that they never stopped caregivers from going in. They never had any COVID. And so we don't have many prototypes of that during our pandemic, but we do have incidences where we allowed caregivers in wave, between the different waves, and during actually the last wave, essential caregivers were allowed in. And they were the least of the issue in some of the homes. In fact, they were probably the only person caring for the person in select homes that were more egregious in issues of care. Next slide, please. So, are there continuing concerns? I guess we would like to conclude and say, yes, there are. There are continuing concerns. And we have a long-term care expansion, not unlike the 1998 expansion. And, there has been concerns in the newspaper about, again, these large 300-bed. And you saw from the earlier histogram that, the expansion is in the for-profit sector. Is that bad? Is it good? It's probably only important depending on the quality of care within the homes, right? And, there's another example, again, Ontario going long haul with private providers, while another province actually observed poor outcomes with the same provider and severed ties. So they're using evidence to make decisions about expansion. And I mean, that's what our plea would be. Use the evidence for where you expand, who you support. And then there was a final quote from a colleague at the Ontario Health Coalition, and she was quoted as saying, "We've been through the worst mass tragedy in long-term care in generations, and those operators who were the worst, who were responsible for the most deaths, they're now going to get the most funding." Now, this is something that has to be looked at from a research point of view. Aspects of it are true. And again, is this the way to make decisions in Ontario? And I think many of you may have seen, Dr. Sima on national TV, where he was talking about this. So many colleagues have expressed concern about, we do need expansion. People are getting older, they will need care, but what should that care look like? And hopefully we'd be using evidence to plan our healthcare sector and actually learn from also what the pandemic has taught us. Next slide, please. So I just listed here, you'll see the colleagues, these are the articles that will be coming out at the end of June. These articles, I can't say it enough, really only supplement our many colleagues who have been in the sector over time and have really provided superb evidence about the understanding of long-term care, what it should look like for our population that requires this service. And so we have a lot of data. And I guess really our research is really only a plea to look at the evidence, to look at the many, many decades of research in this sector, and hopefully use an approach that actually, I think, recognizes the importance of evidence and not to go ahead and just expand as a sort of unilateral strategy to meet a perceived need of a population in need. So with that, I'll close, and we're certainly willing to take any questions, comments. I think Ivy, you're going to chair this session, this part of the session.
Yes, absolutely. You guys are more than welcome to keep the slide up with the different articles and that sort of thing. So we've got a couple of questions. So and just encouraging everybody else to put your questions and comments into the chat. So Stephanie asked, can you speak to the issue of the composition of staffing and staffing mix? So it's beyond just increasing the numbers, but also looking at what types of specialized staff are needed to meet the needs of residents. And I might just augment that about, what are all the different staff that count, in these staffing complements. So if you can speak to that issue, that would be great.
I'll comment on that. I mean, one of the things within the home settings, in the exemplars, that I should say that all staff played a role. You could, when we interviewed dietary, the cleaning staff, the personal support workers, the RN staff, the RPN staff, they tended to work very closely as a team. They knew residents well. It was partly a leadership issue where the leaders pulled the people together. They understood their mutual responsibilities. They were very, very committed to the clients. So I should say that. What we don't have the answers to, and even the acute care sector in healthcare has never really had the answers to, is what is an appropriate ratio of regulated, unregulated staff. And we'll never have the answer to that because each client, is unique. What we do know is more staff is needed. And right now, for example, registered nurses, the number of registered nurses in a home is again legislation. And I remember when they put that in, 1 registered nurse per 12 hours or something like that. That should really be looked at in terms of, I think, residents' needs. We have had the lens put on homes that have 1 personal support worker for 12 residents. And it doesn't take rocket science to recognize that's humanly impossible. Residents have a lot of needs, and if they don't have physical needs, they have emotional needs. And they, in some cases, the staff may be their only family. And therefore, the staff have to be allocated time to spend time with residents, not necessarily doing tasks. I mean, that's another thing. When you look at ratios, there can be focuses on tasks, right? And with a task-based study, you can sometimes miss the emotional support of it and how long that takes and how important it is. And it is very difficult to quantify. Many of us have been in this research field for quite a while, and to try to quantify caring, how much time it's going to take, it's never going to be turned into a pure experimental model. Again, it has to be one that looks at residents' needs. If it's a home of 125 residents, what do those residents look like? What are their needs? And the other thing is their needs change over time. They can change suddenly, as they do in hospitals, or they can change subtly over time. So that means the staff allocation in a 2-week period will not perhaps be the same staff allocation in the next 2-week period. So that whole examination of staffing within a home is something that some homes pay a lot of attention to, others do not necessarily. They may be poorly staffed, they may not have the ability to take a look at the staff ratio, numbers of staff. They may, so again, it has to be looked in a holistic way. I think in the province, we have to look at the homes that really are effective. And exemplar homes have to be modeled. They become, I think, again, a type of standard. And there's a huge variation in this province. And there has to be a closer look at what those homes do. Staffing is one thing. Physical plant is another. Integration of entire staff, dietary, cleaning, their partnerships within their community, their volunteer staff, how they deal with their essential caregivers or their caregivers. That's where I feel, rather than the scientific examination of how many nurses, how many PSWs, it becomes difficult because of the changing scenario of client needs. And a client may go into long-term care being very, able to care for themselves. But over the time, their needs may increase. Therefore, the staffing, the type of staffing may increase. Some of the homes have nurse practitioners in the home. Other homes have none. So that's, again, highly variable. The province, a few years back, paid for some nurse practitioners within homes. But again, there are over 600 homes in Ontario, and it's not standardized. And there's about to be many more. And there's not a prescriptive model, i.e., the homes that have nurse practitioners talk about it highly. They see it as a very useful addition. And so this has to be looked at. So
Yeah,
again,
so that
not
really,
a specific answer, but
no,
yeah.
that was very helpful, and I think it lends nicely to another question that we have, just in terms of, you talked about forms of accountability, and other than inspections. So inspections are a minimum. So what would be other more promising forms of accountability that recognize, some of the points that you've just raised, in terms of it's more than just counting. It's more than just sort of a tick box. There's some quality and qualitative elements that we want to capture. So if you can speak to that would be great.
Well, we know, familiar with Accreditation Canada and their work, more specifically their work in hospital sector, but again, voluntary, but also the work of the National Standards Committee, which again met and are playing an important contribution to, I think, accelerating our framework for standards. And again, within that, staffing is discussed, and that's where we as a group, at least our little group, talked about, should accreditation be mandatory or not? Because accreditation is a very helpful framework. It's a helpful framework to allow you to move towards a goal. If it's not mandatory, you can do it or not do it, obviously. And the homes that are exemplar will do it, right? And then other homes perhaps will not do it for obvious reasons. It is a bit of a stick or a hammer. I don't find it so much. If I have to move through a framework of excellence, like national standards, that's very helpful for me when I'm struggling. Some of the homes are struggling. They're looking for guidance. They, of course, want to improve. They read the newspapers, like anyone else. And again, are struggling with staffing, are struggling with base budget, are struggling with central control, right? Are struggling with their ability to carry out interventions that they might want to carry out. So in terms of a qualitative measure, I think the accreditation standards give a type of framework of which you can set the bar and you can collect data on your own institution, how well you're doing. So, and we saw in the newspapers, we have every single newspaper. Our research team has every single newspaper. It's a little bit of a big pile. The Globe and Mail and the Toronto Star for 2 years, starting in March. And the newspapers did an amazing job of what I'd call qualitative research, and later on in the pandemic, quantitative research, where they gathered over and over again comments from mainly caregivers and about issues in the sector, not to mention the military reports and some more draconian examples we have. And, you know, for Canada, that should never happen again. So I can't see why in this long-term care sector, why they wouldn't embrace standards and mandatory accreditation in order to make the care, again, more standardized across provinces.
Absolutely. And you guys also highlighted the importance of leadership. And, you know, I've worked with the team, Salty Team, Seniors Adding Life to Years, and we did a paper, this was pre-pandemic, on the, you know, the importance of leadership in long-term care. What would you say, you know, was the key leading leadership practices in those homes that fared better than others in regards to leadership?
I think one of them was anticipatory decision making. It's where the leaders could see the needs of not only their residents, but their staff. And they were consistent, and their ability to recognize teams, the importance of teams. Many of them mobilized and changed practices within the pandemic. I mean, some of them had very small, you know, allowed a lot of input by the team, what should be done. It wasn't a command and control. It wasn't done from a central location. It was done right within the home. And again, we looked at, I should say that, you know, we looked at municipal, we looked at not-for-profit, and we looked at some for profit. I mean, again, it wasn't a huge sample, but the leaders, when you examine the answers to the questionnaires and the interviews, you could see this consistency of philosophy. And they knew what to do. They were very honest in their communication. You know, in some of the homes that didn't do so well, I mean, there was this issue of communication with families. It really broke down. The communication was not necessarily consistent. So I would say the anticipatory decision-making, the ability to mobilize and encourage teams, and to reward teams also, and to recognize, I mean, they went above and beyond for their staff. The leaders also were very evident, they talked about this, of going around and visiting patients. They did not closet themselves in an office. We saw, you know, again, in some of our other work where, you know, executive directors stayed in their offices. They said they stayed in their office to prevent cross-infection, you know, all these kinds of things. That's not leadership. So the leaderships, you know, that we looked at in exemplars, they were out in the rooms, they were talking to clients, they were making sure the needs were met, and the team could see them. They were very visible. And 24/7, they reported to work 24/7 during the acute times of the pandemic. So they sort of, the executive directors seemed to trade it off between the directors of nursing and sometimes the nursing supervisors, because there's one on every shift. So, I mean, again, no human being can work 24/7, but they made sure that one or the other was visible to the staff and the patients or the clients. So
I just add to that too, sorry, but the other thing we really saw with the leaders was that they were able to balance the risk with the caring component. And so it wasn't just about, we need to stop all infection at all costs. You know, it was really what works and what works well for my home and my team and my residents. And so, or our team, our residents. And so we saw that there, you know, there was that decision-making that was, you know, thinking about the trade-offs. If we do this, this will happen, but what does that mean? And what are the implications of that? And so, you know, the leaders that were thinking through that and really trying to be, I guess, nimble in a way, in terms of the decision-making, and still work within the limits of what was going on during the pandemic and all the directives that were, you know, being firing at them. At the beginning, they said, you know, within 24 hours, they'd have 7 directives coming through from the ministry, and they had to manage all that and then relay that information in an effective way to ensure that everyone was aware of what was happening. So I think that was another piece that was really important.
That's great. Thanks so much. So we're just going to round off, and I want to give it to both of you. If you had to make a very short 1-minute elevator pitch to the Minister of Health, and if you can also address an issue that just came in terms of what do you do with homes that fail to meet minimum expectations? So what are your key take-home messages to leave us with today?
well, there's 2 points to that, Ivy. What would you do with homes that, and there are some in this province that stand out that need special inspections, and I think there has to be consequences in our inspection reports. You know, clear concept, not just getting a fine of $200,000. They've increased the fines, by the way. The fines used to be 5,000 or 10,000. Now they're 200,000. That's not going to do it. So there has to be consequences for poor client care. And the elevator pitch, Mary, what would you say a good elevator pitch would be?
So I, you know, from my perspective in the teams, I think it's just the sense of, you know, we're talking about people, and we're talking about people's lives and loved ones. We are all affected by this. No one's immune to what's happening. It's important in terms of the care component. And when we consider that it is people and people's lives and loved ones, there needs to be more attention paid to what's going on within the sector, and putting more investments, resources, and infrastructure that will support those things that work well. And those are the types of things we've talked about. So the leadership, the staffing, the training, the education, and, you know, involving the public and making sure that, you know, it's a large system issue that we need to think about ongoing. It shouldn't be a passing thought. It shouldn't be a passing moment. It should be something that's always at the forefront of people's minds. So.
Indeed. Well, thank you so much. Again, we really appreciate it. What important insights you've garnered from this research. And thank you to everybody who joined us. And I will close out there, and have a good afternoon.